if that's okay with you.
Yeah, after you said that, I was going to show some pictures of kids from our study, but then I wasn't sure if we could. They're all safe pictures, so don't worry.
Great. And we have 2 levels of sharing. We can just keep it internal with staff, or we can publish it. So whatever you're comfortable with.
Yeah, I think this is publishable because the pictures are from like articles and stuff.
Okay.
Are you seeing my on-air showing screen thing?
I see LAMA2 related muscular dystrophy.
That's it? Okay, cool.
Perfect. So, Naz, I think what we'll do is we'll get started. I'm just going to have everybody go around and introduce themselves. First of all, thank you so much for doing this. This is really, really helpful for everybody.
My pleasure.
Thank you. So, Sabina, why don't you introduce yourself?
Hi, Naz. I'm Sabine. I'm a volunteer with the CMDIR, and what we focus the MTM Adverse Event Study. I'll just do a couple of other things here.
Cool. Things I wrote we're into doing.
Hi, Naz. My name's Emily, and I'm a volunteer also at the CMDIR. I'm working with Sabine on the MTM project.
Okay.
You know me. I'm Rachel.
Hi, Naz. My name is Janet Young, and I'm here in the CMDIR office help, volunteer.
Nice to meet you.
And she keeps organized. So I think somebody else joined us on the line as well. Lindsay's on the line. Lindsay, do you want to just unmute yourself and introduce yourself?
Sure. My name is Lindsay Swanson. I'm calling in from the Beggs Laboratory at Boston Children's Hospital.
Nice. That's where I did my neurology training.
Excellent. I just heard that from Alicia. She says hello.
Oh, tell her I said hi.
I will.
Great. Naz, do you want to just take a brief moment and introduce yourself first before getting started, and then go ahead and launch in? This is pretty informal, and we always open it up for questions while you're going through, if that's you. And again, thank you so much for this wonderful opportunity to learn.
Oh, it's a pleasure. So for myself, I am a now pediatric neuromuscular specialist. I did my training in peds and then did peds neurology, as I mentioned, at Children's in Boston, where Lindsay's at. And then I did neuromuscular training in an adult neuromuscular fellowship because there weren't any formal ACGME training programs available. So I did it at Mass General and the Brigham in Boston. And decided to take a shot at research by becoming a clinical research fellow with Karsten Bonneman here at the NIH. And so that's what I do for now, and then that's how I got connected with Anne and CureCMD. And that's pretty much it.
What does the DO stand for behind?
Oh yeah, so there's 2 types of physicians. There's DOs and MDs. I'm not sure how much you have in California, but it's where I grew up in Pennsylvania. And so it's a doctor of osteopathic medicine, which basically allows you to go through the same training, but you get some additional training in osteopathy, which is musculoskeletal techniques or muscle energy. And you could take the path of becoming an osteopathic specialist, which is usually a cash industry and makes a lot of money, or you can go off and do residency in any of the other training programs available to MDs as well.
All right, thank you.
Uh-huh.
Okay.
Okay, you want me to get started?
Yep.
Okay, so this talk is on LAMA2, congenital muscular muscular dystrophies here. And I'll go through the details about this, hopefully in a way that's very communicative and educational. Let me see here if this is going to work. Okay. So just to give you an overview, which I'm sure all of you are familiar with, but just as a review here to place where I'm coming from, congenital muscular dystrophies are a heterogeneous group of inherited muscle disorders with common clinical manifestations that include muscle weakness with onset at birth to early infancy that may improve, worsen, or stabilize over time. They have a prognosis that's often dependent upon the degree of weakness, joint contractures, spinal deformities, and respiratory compromise. And there are subtypes, one of which we're going to speak today, which is laminin alpha 2 related muscular dystrophy. collagen-6 deficient muscular dystrophy, and dystroglycanopathies, which include, these are the genes that are involved with the dystroglycanopathies, POMT1, POMT2, FKTN, FKRP, large. I mean, I'm not going to expect you to remember all of these, but just to give you an idea that there's a lot of them here, and I'll try to place these for you as well as we go through the presentation. So basically, when people talk about congenital muscular dystrophies, can you see my cursor by any chance?
Mm-hmm. Yes.
Okay. All right. This GoToMeeting sidebar thing keeps showing up on the screen, so I don't know if that's what you're seeing as well. I'm trying to move it to the side here.
The little orange arrow should pop it over to the right.
Oh, okay. Oh, that totally worked. Awesome. Okay. So basically, here's a picture of the outside of the muscle. So here's the sarcolemma, and this is what you call the extracellular space. Intracellular space is down below, and then the extracellular matrix. So oftentimes when you speak about a lot of these muscle disorders, this is the region in which we're talking about. So these are essentially proteins that either span the membrane. So you can see there's beta-dystroglycanopathy, sarcospan, and then these are delta-sarcoglycan, beta-sarcoglycan, alpha-sarcoglycan, gamma-sarcoglycan. You can see like each of these can cause different types of disorders. And then there's these areas that get glycosylated, and this is on alpha-dystroglycan. These can lead to their own slew of other disorders, which we just reviewed a little bit earlier in terms of the genes that are involved with this. And the genes that are involved with this can either cause like poor formation of these regions here, or it can cause shorter regions that don't allow other things to attach to them, for example, such as laminin-2. Laminin-2 exists right here, and it also connects into the collagen, into the extracellular matrix here, which is governed by collagen-6. So when you hear about collagen-6 disorders, we're dealing mainly with here. When you're dealing with laminin-2, you're dealing with this little protein right here, and you're dealing with essentially oftentimes how it connects to alpha-dystroglycan as well, just to give you an arrangement in space about this. And laminin-2-on-1 is, or myrisin as it's also known as, is the major laminin isoform found in the basement membrane of muscle fibers. It can also be found around Schwann cells in the peripheral nervous system. Schwann cells create myelin that covers the peripheral nerves. It can also be in the cerebral capillary blood vessels between the astrocyte foot processes and the vessels, and it can be a component of the lamina limitans in the surface of the brain. The reason why it's interesting to note the blood vessels and the brain is because sometimes it's suspected that this can lead to some of the changes in brain MRIs that you can see in some of these laminin alpha-2 patients. There's evidence of membrane instability in these patients, oftentimes demonstrated by a mild to markedly increased CK level. And CK is obviously the, as you've heard a few times, so just to kind of break it down, it's the muscle breakdown product. So if there's any type of membrane instability, you're going to see CKs go up. There are also muscle diseases where CK levels don't go up, but what's characteristic of LAMA2 is that CK levels will go up. They may sometimes be normal, though. And there also appears to be a detachment of the muscle from the matrix external to the sarcolemma, and consequently an increased rate of apoptosis that has been seen in mice and fish. So thinking about this laminin-2 here, just remember it attaches to the alpha-dystroglycan, which then anchors to beta-dystroglycan in the sarcolemma, but it also has an attachment to the extracellular matrix here. And this is kind of like scaffolding that holds everything in place, and you can imagine if there's a problem with this laminin-2, you can have some disconnect between these two regions here. I hope I'm explaining this okay. Just slow me down if you have any questions.
Doing great.
Okay, great. So laminin-2, alpha-2 related muscular dystrophy can manifest as congenital hypotonia, delayed or arrested motor milestones, feeding difficulties, and muscle weakness, which may be absent or slowly progressive, and respiratory insufficiency and orthopedic complications early or beyond 10 to 15 years of age, and I'll go through these details in a little bit. You can also sometimes see joint contractures and spinal rigidity. So here are a few pictures, and I'm going to show you what we typically see in these patients. So this is a de-identified patient from our clinic here. You can feel free to put this on your website here for review, but basically what we're going to see here is there's scoliosis. This is actually an older patient. She's in her 50s, and you can see her scoliosis here. Oops, sorry. Other things that we look at are joint contractures. So she's just not holding, this child here isn't just holding her elbows in this position. She can't extend her elbows out further than that. That's one area. The other thing that you can look at is sometimes there's muscle wasting that you can see just by looking at these patients, like these axillary folds here. It means that the pectoralis muscle is a little atrophic or smaller. You can also see that these children have myopathic faces, which basically entails poor movement of the face or inability to really move the face, so they get this kind of elongated appearance to their face. They may not be able to close their eyes very tightly. Unfortunately, this is blacked out because this was from an article here, but if you have these children squint their eyes, you can easily pull them apart. If you ask them to smile, they might not get these creases here, or they might have something called a transverse smile, where the smile just goes across and it actually doesn't go up, and you don't see the cheek definition that you usually do. The other thing is that these kids with the myopathic face tend to keep their mouths open, so it's kind of sagging open. And the other thing that's pretty unique to Marison patients is that they often have an enlarged tongue. So here you have the myopathic face, some muscle atrophy. For a kid her age, the tone in her abdominal muscle is also low. It shouldn't be kind of sticking out like this. It could be a little bit fitter. She has these contractures here. I don't have a picture of whether or not she has scoliosis, but it is possible because one shoulder appears higher than the other. Then going on to the same child here, they noted in the article that I got these photos from that she can't extend her knees any further. So these are contractures in her knees as well, and you can tell that she also has low tone in her neck because when they're pulling her up, and again you can see the contractures here, she has a hard time lifting it up, lifting her head up. So the genetics, so it's a recessive mutation in the LAMA2 gene encoding for the alpha-2 chain of the laminin on chromosome 6q, and I just learned this from a geneticist, actually. It's not 22, it's 22 and Q23. But everybody says 22 and 23, but I figured I'd spread the word. And it presents as complete deficiency, also known as MDC1A. And these kids usually get to sitting and standing with support as their maximal motor ability and don't usually acquire independent ambulation. And then you may have partial deficiency, or MDC1B, and there's a variety of the severity there. Delayed onset is possible, and they may have early respiratory failure. So another way that we diagnose laminin alpha-2 related muscular dystrophy is through biopsy. So oftentimes we'll have the genetic testing which will show us where the mutation's at, but sometimes these kids actually come with a diagnosis based on their muscle biopsy. And here we have an H&Z stain, which is a pretty classic stain for muscle. And what you're supposed to see with this muscle biopsy is that these fibers are supposed to look relatively round, not totally rounded, kind of polygonal, but not angulated, not with sharp angles. But they have a nice kind of discrete pattern that is full. It'll take up the entire screen here, and pretty much they're of the same size. And the nuclei in the muscle are supposed to be on the outside of the cells. And basically what you have here is that you'll see a lot of variation in the fiber size and a lot of extra connective tissue. Unfortunately, this image doesn't show the nuclei, the presence of the nuclei, but the nuclei may be on the outside, but they also may be on the inside, and when your nuclei go into the inside, that can be a sign of regeneration or your muscle trying to come back and rebuild itself. So this H&E gives you a good idea of what the kind of anatomy of the musculature is on a microscopic level. It doesn't tell you much more than that. In order to identify whether or not there's Marison deficiency, you have to do something called immunohistochemistry, which is to try to bind an antibody that's already been developed to this protein to the regions where you think the protein should be attached. So here is a normal person who has normal Marison staining. And you can see that this antibody stain actually attaches to the Marison that's distributed all throughout the basement membrane of these muscle fibers here. So you can see that this is normal, and you can see a nice outline of this tissue all throughout. Now, granted, there is variation in fiber size in this patient, and that's abnormal, but with regards to Marison staining, there is Marison positive. This patient does not have any Marison on the outside here that's attaching to it. So here you would call Mersin deficiency. Now, when you make the diagnosis of partial versus complete, what that means is that there are parts that have Mersin staining on the muscle biopsy interspersed with areas that don't. When you have complete, it's suspected that the entire thing doesn't have any Mersin staining, but obviously that could be a sampling error too. So that's a little bit of a gray area when it comes to this diagnosis. But when you hear the phrase partial versus complete, this is what it refers to. It's mainly referring to the muscle biopsy. Unique findings to laminin alpha-2 related muscular dystrophy, relatively unique findings. I'm just going to go through these because if you hear about this, it should kind of ring a bell and you should start thinking about laminin alpha-2 is cognitive impairment. Now, the majority of these patients are normal, but you may sometimes see this, and Anne will often talk about this kind of spaciness in these patients. It's really hard to identify, but we're trying to do this with a study, a neuropsychological study that's going on the patients that we see here at the NIH in the summer study, is trying to hone in on this kind of spaciness and kind of staring off into the space intermittently that some of these patients do exhibit. But we haven't been able to identify it, and so far a lot of these kids have done pretty well on standard neuropsychological testing. When you do hear about cognitive impairment, though, you should think about other CMDs as well, so alpha-dystroglycanopathies, and there's another congenital muscular dystrophy associated with adducted thumbs, cerebellar hypoplasia, or smaller size of a cerebellum in the brain, ptosis, and external ophthalmoplegia. In terms of brain MRI findings, so there are brain MRI findings that are unique to this patient population. They have a characteristic white matter signal, which I'll show you shortly, and possible brain malformations. So 5% of these patients are associated with occipital pachy or agyria and pontocerebellar atrophy, which is rare, and I'll go through these for you as well. And when you see these things, you should also consider, along with this, the possible diagnosis of alpha-dystroglycanopathy. So it's not 100% unique to LAMA2, but it sure does narrow down the range of what you're looking for. In about 20 to 30% of these patients, you can see seizures. And a demyelinating motor neuropathy may be present. And again, demyelinating means that your myelin's breaking down. And as you recall from before, laminin can be found inside of the Schwann cells, which are the cells responsible for myelinating your peripheral nerves. So laminin alpha-2 related muscular dystrophy brain MRIs have some characteristic findings. So when you do T2 images here, and T2 and T1 are different protocols that show different areas of the brain as light or dark. So what you see here is that this is the white matter of the brain. Oops, sorry. This is the white matter of the brain, and inside here is the gray matter. Here's the skull. And what you're seeing in here are some white matter changes, meaning that there's some increased signal in these in a non-specific distribution that can be seen. And oftentimes this spares the corpus callosum, and I'll see if, that's basically the region of the that goes between the two hemispheres, and the internal capsule, which has a lot of the, let's see if I can get a picture of that and show you what region of the brain that is. The nature of the changes isn't known, but again, when you're thinking about where laminin exists, we were talking about how it could be in the blood vessels, and the question remains whether or not this could be kind of an edema type of picture where there's some fluid leaking out of here. It's not clear. It's also not clear as to whether or not the presence of these white matter changes have any correlation whatsoever with cognitive impairment or seizure activity, but that's also identifying that is also part, a goal of the LAMA2 related muscular dystrophy study that we have in terms of their cognitive impairment and seizure disorders in our summer weekend study. Here's another image that kind of shows this white matter changes again. These are the white matter changes. This is the internal capsule in the brain, and you could see that it's spared. Corpus callosum is spared. Now, the interesting thing that's an additional finding on here on the brain MRI is that there is some what we call pachygyria back here in the occipital lobe. So this is the front of the brain here. You would expect on a lower level, more inferiorly, that the eyes would be placed here. Posteriorly, here's the occipital lobe. And you can see these brain malformations typically, for whatever reason, I'm not sure, in the occipital lobe in the brain in patients with myrosin-deficient congenital muscular dystrophy. So back here. Now, again, another thing that can sometimes be found are temporal lobe cysts. So these are little fluid-filled cysts in the temporal lobe. Unclear as to how these present or why these present in some patients, but they may be seen. Now, for laminin alpha-2 related muscular dystrophies, there are therapeutic possibilities that have been introduced, and I'm going to go through some of these as well. One thing is the suppression of apoptosis. Apoptosis is programmed cell death. There is, in animal models of LAMA2, there has been evidence of ongoing apoptosis in the muscle. And there have been some medications that have been proposed that might be able to reduce this apoptosis. And one of them is omega pill. That's a drug that we hope to try to put into a clinical trial here at the NIH in conjunction with the University College of London. And hopefully that'll work out, but this has so far only been seen in animal models. Then the other thing that you can try to do, and again trying to think about that picture of the laminin 2 between the extracellular matrix and the alpha-dystroglycan, is to restore muscle function by providing a connection between the alpha-dystroglycan and the basement membrane. So they have been thinking about using a mini gene derived from agrin, which is a protein with binding capacity to both alpha-dystroglycan as well as laminin. So a lot of this is very similar to a construction site. So if you're missing one base connection between two areas, why not try to substitute it with, like, if it's not necessarily the usual nice heavy wood that you like to use, try to take something else and slab it on with 2 nails and see if that can actually hold everything in place. I think about this whole region mainly like a construction site. It kind of helps with the analogy, with the cartoon in your head if you can develop one about this. So agrin is one type of thing that might be able to help with that. The other thing is that you can sometimes also try to ameliorate fibrosis, which has been seen as a common pathologic finding in patients with laminin alpha-2. And fibrosis is essentially what happens after the muscles break down, and they don't really regenerate that well, and it's kind of like a thicker texture type of material that's almost like a scar within the muscle tissue. I do EMGs. I'm not sure if you're familiar with EMGs, but if you stick you use needles to check the muscle on a regular basis and in different regions, and if you do it enough, you know what muscle feels like when you stick a needle through it. I'm not sure if any of you have any experience with immunizations and whatnot. If a patient has fibrosis and you stick that needle in, so when you try to put it in, first of all, it's harder to get the needle through, and it's sticky and harder to get the needle out. So what they try to do in this situation is try to ameliorate the fibrosis with some medication. And, oops, sorry, there's a typo there. The way that they've distinguished this is by identifying TGF-beta expression as a promoter of fibrosis. And angiotensin II promotes TGF-beta expression, and an angiotensin II type 1 receptor antagonist, which is a common blood pressure medication also known as losartan, can actually decrease TGF-beta activation and improve regeneration and pathology, potentially. So that's another thing to consider in terms of therapeutic possibilities. And then finally, there's gene therapy via an AAV vector, which is basically a virus's vector. And just to kind of give you an idea of how this works, so that you're more familiar with it, even if you're in touch with patients who talk about it or go to talks. So viruses essentially live in something that almost looks like a spaceship. It's a little pentagon with a landing pad, essentially. And viruses tend to have their own DNA. So this virus, AAV, has a viral DNA inside of it that isn't known to cause human disease. And what they do is they empty out this DNA, and then they put in another DNA. And you would think, this is great, so let's put in some laminin alpha-2, because what happens is they will then put in the virus, and then the virus is going to go use its module to go inject its DNA, which will then mix in with the human DNA and hopefully replace what's missing or fix what's abnormal. But the problem is that oftentimes with these muscle diseases, the DNA is too large to fit into the actual vessel that's supposed to deliver it. So that happens with dystrophin, and it's also the case with laminin alpha 2. So the cDNA is too large, and so they've come up with laminin 111 instead of 211 as a feasible alternative. So if you hear about AAV, it's oftentimes with a substitute or an understudy in a way. But as for now, aside from the therapeutic possibilities, we do have things that we do to manage these patients, not necessarily cure, unfortunately, but management is, it's half the battle there. So you want to assess the spine and the joint deformities. So oftentimes when we see patients in clinic, especially ones that are walking with the partial Mersin deficiency, there are a lot of limitations that can come about from restriction of joint motion even sooner than limitations due to muscle weakness. So you have to take that into consideration. And if it's the case that someone, for example, has restriction with dorsiflexion or pointing their toes and their feet up towards their head, and they tend to walk on their toes all the time, you can see how it's easy for them to fall, trip, hurt themselves, which is just a nightmare because what happens as a result of that? Then they end up being bedbound for a while. Then they get muscle atrophy from not using it. Then their vitamin D drops even further. Then they get deconditioned. So the best thing that you want to do is try to keep their joints as mobile as possible to prevent falls and also to retain function. Same thing goes for the spine. You want to try to keep the spine as straight as possible, either with bracing or with surgery, but that's kind of a hazy issue in terms of when to address starting surgery, because once you have spine surgery, you can't actually bend your spine. But the reason why you actually want to make sure that the spine is nice and straight is because you want to make sure that these kids can actually sit up straight, you reduce the pain, and also primarily it helps with the respiratory function. So you can imagine that when you have a curved spine, it's going to compress your rib cage to the point where the room that you need to take a nice big breath is going to be limited, and this leads to something called problems. It's like a restrictive lung disease because you don't have that room to expand your lungs. And as you can imagine, that really leaves them predisposed to potentially having pneumonias that they might not be able to recover from. It also limits their abilities to produce a good cough. It limits their ability to exercise their diaphragm appropriately. So there's a lot of problems that come out about that. So really paying attention to joint deformities and spine deformities are a major area of concern and should be addressed very aggressively. And you can do this by seeing orthopedic docs and also getting regular physical therapy. Feeding and nutrition is also very important. Sometimes these kids don't eat well. And obviously this is going to lead to problems in terms of bone health and also in terms of feeding their muscle, because obviously you need protein to build muscle. So if you're not getting the components that you need to build the muscle structure that you want to have, at least, or retain the muscle structure that you do have, then it's going to lead to more atrophy of the muscle, which is something they definitely don't need. Bone health, as I mentioned before, because you want to prevent the bone fractures. Vitamin D and calcium, and you can monitor this with a DEXA scan. You also want to monitor cardiac function. So typically laminin alpha 2 isn't associated with heart disease. But what happens is with this restrictive lung disease that they might get from their spine deformities, and also with decreased excursion of the diaphragm, because the diaphragm itself is a muscle, you might get increased pressure within the lung itself. Increased pressure within the lung itself leads to increased pressure in the heart on the right side, and this can actually lead to right heart failure or something known as cor pulmonale, secondary to hypertension, either because the blood vessels are going through a stiffer, mainly because the blood vessels are trying to traverse through a stiffer lung. And you can assess, pay close attention to this with an echocardiogram, which isn't necessarily something that needs to be pursued very aggressively, for example, as in a Duchenne patient, but should be checked at least probably every 2 years. You also want to pay close attention to their respiratory function with regular pulmonary function tests. Obviously, you can only perform these pulmonary function tests on kids that are a little bit older and able to participate, probably around the age of 5. And the other important thing with this is that you need to do this in both the supine and the seated positions. So if you are to check a patient who's sitting upwards, if you want to check their functional vital capacity or how much air they can hold in, or the maximum expiratory pressure, what the forces that they push out with, or the force that they push in with is known as the maximal inspiratory pressure. You can check that in the seated position, and you have more excursion of the diaphragm in the seated or the standing position because gravity is helping along. But the minute you put these kids in a supine position, gravity is taken away, and this diaphragm, which might be pulled down by gravity and giving more space for lung excursion, is going to kind of dome upward and create less space for excursion, and you're not going to have the assistance of gravity pulling it down when you want to take a deep breath in. And thus, the values of the functional vital capacity, or how much air that they can actually retain, drop pretty significantly. So that's something that you have to take into consideration, is to make sure that you get these supine tests as well. The other way that you can assess respiratory function is also through polysomnography, which is just a sleep study. And you want to rule out nocturnal hypoventilation, which oftentimes takes place when the FVC drops less than 40%. And then these kids can also have something called hypercapnia, which is retention of carbon dioxide. And one of the symptoms of this is when kids complain of headaches as they wake up in the morning. And then that's pretty much it. So I hope that that was a good review for you, and I'll take any questions.
Great. Naz, I wanted to point out that there have been a couple of case reports now in teenagers with LAMA2 related dystrophy of having arrhythmias. There was a nice paper that was just published, I think within the last year, of an individual with supraventricular arrhythmia. And so I think, and then there were some anecdotal reports from France as well. So I think one of the things that we haven't traditionally thought about is in these patients, they've been thought of on echocardiogram of having kind of a subclinical cardiomyopathy or an enlarged heart. And we've never really been sure what to think about that. But there may be also a slightly increased risk of arrhythmia only, again, in late teenage years, kind of, 17 through early adulthood. But I think it's something to watch for in these patients as well.
Yeah, it's really interesting. Definitely important.
Yeah. This was a fantastic review and so incredibly helpful for us to get a better sense of not only kind of what people look like, how the diagnosis is made, and then both clinical management and possible therapies. Does anybody have any questions at all?
Hi guys, this is Sarah. I'm sorry I joined your presentation late, but I want to thank you also. It was very informative, and it was really nice to sort of meet you, I guess, and to hear your talk. And one thing I wanted to mention is I just love that you are assessing people's breathing and supine and laying down, because in my son it makes a big difference. And I would add on top of that is measure people's breathing in their brace, their scoliosis brace, because you mentioned that as being a clinical factor, and if they're doing bracing, and then also out of their brace, because definitely got into a situation with a couple of braces that were literally impairing my son's breathing by about 20%. Wow. And if it wasn't that I had asked for that test, it'd be like, God, why is he so tired? Well, he got bigger and his brace got too tight, and now he can't breathe. So I'm glad that you measure the different functions, and maybe you do that in the brace anyway, but my orthopedic surgeon is now going to be purchasing a right respirometer to measure before and after breathing and supine and sitting in the brace for his patients, so that's great.
Yeah, that's great. I mean, I haven't heard of, we don't typically measure people's breathing in their braces, but I think that that's a really, really important point to make, because that adds a restriction in and of itself in terms of having the ribs expand the way that they should.
Yeah, we've actually had braces that Adam, when my son had them, his breathing actually improved, and you're like, wow, there's success. But then when you look at one and you say, wow, that's a 20% reduction, you got to scratch your head and ask yourself, maybe we needed a little modification or something.
Right, right. Yeah, there have been some people that have thought about abdominal bracing to support the diaphragm as well and help with respiration, so it's kind of a fine line, I guess.
I have a quick question for you. You mentioned earlier that they were developing some medication to decrease the fibrosis in the muscle. What actually, clinically, how does that change the way that a person functions to get rid of that fibrosis?
So in theory, if you can, so that's a good question. So in theory, if you get rid of the fibrosis, then the muscle will be less stiff. And could that, in theory, help out with that? But again, it's a great question because if you do get rid of the fibrosis, is it going to really change anything in terms of muscle regeneration? You know, you might get rid of the fibrotic tissue. If you look at, right here, let me see here. So you might get rid of this extra connective tissue or this fibrosis. But what are you doing about all the muscle that's left behind? Is it just going to dissolve this? I'm not sure. I'm not sure if it's going to really change much, but I could imagine that maybe it helps a little bit with the stiffness that might occur in the muscle in and of itself. But other than that, I can't tell you.
There was a nice paper that was just published in the last month that actually looked at that question. So not specifically that question, but is kind of related. So in the distal glycanopathies in the mouse model called the large MYD mouse model, they looked at whether the satellite cell population is normal or increased. So what is the ability for the muscle to regenerate? And what they found is that though the satellite cell number is larger, so the muscle is trying to regenerate because it is a distal glycanopathy, the muscle is degenerating and it is kind of breaking apart, and so there's a signal, oh, stem cells, you need to get busy and create more muscle fibers, right? Mm-hmm. And what they found is that when they test those stem cells in the muscle of the mouse, they are not capable of creating new muscle. But if they take those stem cells out of the muscle, they start to work normally. So they actually think that the extracellular matrix, which is all of that fibrosis, is inhibiting regeneration. And one of the thoughts is in laminin alpha-2, where we've seen muscle biopsy slides at the age of like 14 months, where it's already so apparent that they have these extracellular matrix changes with fibrosis, that part of the reason why they are so weak so early is because they have a complete failure of regeneration. Because they have so much extracellular matrix, it becomes an inhospitable host environment for stem cells. The stem cells are just not able to manage. And what is very interesting in this paper that was just published is they take these stem cells and they put them on a laminin matrix. So this is laminin alpha-2, a laminin matrix. They show that the stem cells start to actually regenerate really well. But if they then put them on a slide that has collagen or fibronectin, which are key ingredients in this type of fibrotic change, the stem cells do not regenerate very well. So all of this helps explain that stem cells and the ability to create new muscle and regenerate is completely in part driven by extracellular matrix change. Increase the fibrosis, then you could make the stem cell environment better and allow improved regeneration. The question always is at what time would you need to start that process, especially in a very early onset disease, to even catch up with the regeneration. So I think that that's one of the big questions, but it's a great question. What would it do immediately for how somebody feels and functions? That's the purpose of a clinical trial. And they haven't tried it in humans yet, so we actually don't know whether it would improve how a human feels or functions. In the DYW animal model for laminin alpha-2, it did improve its motor function using losartan, the antifibrotic, but it is still unclear what it would do in humans. And over the long term, how early would you need to give it to see an effect? How big would your effect be? We don't know. Any other questions? No? Question, Dana? No? Thank you, Naz, so incredibly much for this fantastic presentation.
Oh, my pleasure. I hope it's what you were looking for.
It absolutely is. I mean, it really is great, and you can refer back to it. And I think also for the community to be able to come to this and actually see the presentation and hear it will be a wonderful resource. So thank you very, very much for making yourself available and pulling together these fantastic slides.
Oh, no problem. My pleasure.
Great. Sounds good.
Okay.
Well, thanks for being in touch.
All right. Okay. Nice meeting you all. Take care.
Bye-bye.
All right. Bye-bye.
Bye. Thank you.
Bye.